All right, good morning, everyone. How many of you have heard of PAP nap? How many run PAP naps in their sleep center? One? Okay. All right, we're going to talk about that and getting one set up, and something I hope you can take back to your centers and get this program up and running. So, objectives, we're going to talk about what is a PAP nap, and all of you all have heard of it, so that's a good thing. Its role in the sleep center, and its role in adherence and compliance with therapy. I think that's probably the most important takeaway from this. You know, what does it do for our patients in general? And of course, how to roll out a program. That's the other piece that we're going to talk about. Disclosures, a little bit about me. I work, as Candy said, work for Mannikarote LLC. We're an HME company based out of Dallas-Fort Worth, and we cover the state of Texas. And also I work, when I say work, I'm a co-host, co-producer of Sleep Tech Talk, the sleep podcast. I was just talking to a few folks about it. We have all the latest information about technology. We actually started this as a voice for sleep technologists on the podcast space. Our YouTube following is really big right now, and we would encourage you to, if you haven't checked it out already, encourage you to look it up. We just published an episode earlier this week. Yeah. All right, so we talked about how many people here know what have heard of PAP nap. So can anybody tell me what it is? No? Yes? Sorry, say that again? Check to see if the pressures are right for the CPAP. That is one piece of it. Yes, you're correct. Anybody else? You were saying something, sir? Acclimation to PAP therapy. Very good. That's a huge piece of it. Yes. Somebody said something else? Same thing? Okay. All right, fantastic. Those are all pieces of it. And according to the Cleveland Clinic, this is the definition for PAP nap, positive airway pressure nap. Daytime study for patients who have anxiety about starting the PAP therapy, claustrophobic, or having difficulty tolerating PAP therapy for their sleep-related breathing disorder. So it combines all these pieces that you just said, whether it's checking for the pressure, if it's the right pressure for the patient, acclimatizing the patient to therapy. These are all big parts of it. But I want you to also keep in mind these pieces right here when it comes to the acclimatization part is the anxiety, and claustrophobia and difficulty tolerating, but in particular exciting and claustrophobia. We'll be talking about that a little more in detail as we move forward. So let's break it down. What is this? Has anybody heard of Dr. Barry Krakow? I don't know if I'm pronouncing his name properly. So Dr. Krakow wrote an article in one of the journals. So this is a peer-reviewed article basically it was about a PAP nap. That's what it was. And it was in 2008 that he wrote about it. And his objective was to use the impact of daytime sleep medical procedure called the PAP nap, which is what he called on adherence. Somebody talked about adherence earlier. And among insomnia patients that had sleep disordered breathing. And so what he had called it was a limited daytime study. That's what he called it. And he nicknamed it PAP nap. So we're going to be breaking it down, so we're going to go pretty detailed in the article in order for us to understand better on how to roll it out. So this is based on, what he did was he based it on the current procedure, or the CPT codes basically. He based it on CPT codes, and it combines the psychological and physiological treatments in one procedure. So I talked a little bit about anxiety and claustrophobia. These are the psychological pieces of the PAP nap, and that's a huge part of Dr. Krakow's way of approaching PAP naps for the patient. And then increases contact time between sleep disorder patients and the technologists. You know that's an important thing, right? Yes. And to enhance PAP therapy adherence. Now you heard Emerson talk yesterday about AI and how it functions, and then Robert also talked about all the new advances in sleep technology and sleep medicine. But the common thread in between all of that is you cannot take away the place of the technologist. The technologist's role is changing. Okay, we're no longer just people that sit at night and observe and write down what's going on at night. There's a whole lot more to this, and a huge piece of that is education. Okay, so the stronger you are in your knowledge of sleep disorders, we were talking a little bit about Inspire procedures. Patients come in and ask about, hey, how do I get that thing where I do this and then it turns on and I don't need a mask? The more knowledge you have, the better equipped you are to move forward with those patients. And this was written in a peer-reviewed article that increases contact time between sleep disorder patients and and sleep techs. Okay? Yes. I don't use that word too often these days. Yes, ma'am.
I've only done a couple, but it's when I used to work for this doctor, like say you had somebody that was having trouble with your sleep out, they wasn't sleeping with the client, so he would bring them back. And I think he had them like 4 hours instead of 5 hours.
Right.
And you started them out, and then, so is that not right? You just try to get them at a is that what that is?
Okay, so for the sake of the others who didn't hear and for the folks online, what she asked was the doctor would bring them in and have a limited time, about 4 or 5 hours, with the patient sleeping on this, and is that the way the procedure is? Yes, you're right, and we're going to talk about that in detail. Okay, so the cool thing that Barry Krakow did in his study, and the link to the article is here, that he did in his study, is he actually detailed every single piece of the procedure, and we're going to be talking about that in detail. Okay. So thanks for asking that. All right, so again, going into the details of the article, he used a framework that talks about the mind-body disorder in relation to PAP therapy for that patient, okay? Anxiety, claustrophobia, and also intolerance to therapy. So it combined all those pieces here. So we talked about acclimatization. You guys do desensitization when you put the patient on CPAP, right? That's normally what we do. We start them off at the lower pressure, and they say the pressure is too high, and you know it's at 4, and they say it's too high. You say 1 second, you walk back into the control room for 2 minutes, do nothing, and come back in and ask, how was it? Say it's much better, right? That's all desensitization, right? So that was part of this. Emotion-focused therapy to overcome adverse emotional reaction. This is again, when it comes to the anxiety and claustrophobia part. How many of you have gone into the room when the patient is, you can see they're freaking out with the mask on. You've gone in there, you held their hand, and you breathed with them. You said, hey, join me, let's breathe together, and you breathe in, breathe out, get that anxiety down on the patient. This is a huge piece of the PAP nap as well. Mental imagery to divert patient attention from the mask or pressure sensations. Again, getting them to think, focus, and disassociate from the fact that they have this mask on. This is, again, a huge psychological piece of it. Who better than a sleep technologist to be able to guide a patient through that, right? And finally, a physiological exposure to PAP therapy, obviously using the machine. And then to your point about how many hours, in this particular study, it was over a 100-minute period, okay? So that's a little over 1.5 hours that Dr. Krakow and his team did. So, what's that? Oh, hey, no problem. So, patients treated with the PAP nap test, about 39 of them compared to the control group of 60. This wasn't a huge number, a little less than 100 people, but it was the beginning of this program to get to the bottom of how do you do this particular program. And remember, these patients were insomnia patients with sleep disordered breathing. So basically they couldn't sleep, but they also had some sort of sleep apneic issue, sleep disordered breathing. So what were the results of this study? So all 99 insomnia patients were diagnosed with sleep disordered breathing, just like we said, and they had about an AHI of average AHI of about 26 per hour and RDI of 49. Now, everybody had these issues, right? That's what we see here. And they reported a history of psychiatric disorders or symptoms as well as resistance to PAP therapy. The psychiatric disorders could have been any one of these things we talked about. Anxiety, some other issue due to creating the insomnia, claustrophobia. It could have been any one of these things. And then resistance to PAP therapy. You all know that very well. I can't do this. I don't want to use this. Rip off the mask, blah, blah, blah. So let's take a look at what happened with that, with the results. So the 39 patients that completed it, 90% of them completed the entire night. This is before the PAP nap, compared to 63% in the control group. So in the control group, which were the majority of them, only 63% actually had a full titration study at night, whereas the other group who had the PAP nap, they all had titration studies. So those people who had the overnight studies, 85% used and got their CPAPs at home, compared to the control group, only 35% of them. So what that means is that control group, 35% said, no, I am not going to do this. That was it. Remember, this is 2008, before Inspire and all was out. Now, here's the interesting thing. 67% of the NAP-tested group maintained regular use of CPAP, and compared to 23% of the control group. So after the PAP nap, 63% used their CPAP therapy. So using standards from the field of sleep medicine, and adherence from 49% to 56% for those that were given the PAP nap. That's a huge market increase of that, compared to 12 to 17% who did not get PAP nap. Okay? And if anybody here runs labs, this is the thing. Everything was reimbursed using this particular code, 9580752. We're going to talk a little bit about that as well. Why is this important, by the way, before we continue? Sorry? You get paid? Very good. What's that? Otherwise, you're not going to do it, right? Yes. Exactly. I mean, it's important to have reimbursement in order for us to continue doing what we're doing, right? It's not a money grab. It's a version, it is a process or something that we need in order to perpetuate the good that we provide to our patients, okay? So this is an extremely important piece. What I found was most interesting about this particular study was this is a peer-reviewed article, and he actually used the CPT code in a peer-reviewed article. So to me, that was fascinating.
Does this require pre-authorization?
So I'm not a billing expert, but I'm gonna agree with her. She said yes. So the question was, does this require a pre-auth? And he said yes. So, well, liability, blah blah blah. I'm not lawyer. I'm not billing guy. So, all right. So what's happened since then? That was 2008. What's happened since then? All of y'all raise your hand. We have one person that said that they do it. So believe it or not, Dr. Krakow's team had done a follow-up study in 2020. And Dr. Ulibarri, I may be butchering the name, and I apologize. Dr. Ulibarri actually wrote the previous article in 2008 with Dr. Krakow. Dr. Ulibarri was the second author for that article. Now, in 2020, when the article was published, Dr. Ulibarri was the first author, and Dr. Krakow was the second author. So that's kind of cool that they took the next step forward. This was released in 2020, but the study was done in 2018. So it was exactly 10 years after the published. So that was their thing, is what happened 10 years later. So this is interesting also for me because it really tells you how much has this been utilized since then. So once again, they talk about how using PAP therapy is still a barrier for people because of all sorts of reasons. And the PAP nap, I like the way they use this. Again, this is a peer-reviewed article once again, is they used PAP nap to test drive the CPAP. And it was a great, beautiful way to explain what is actually happening during the PAP nap. So how did they do it? Let's look at this again. So what they did was a retrospective chart review on 139 patients. And these were all diagnosed with OSA or upper airway resistance syndrome. Okay, and so you see that the majority of them were OSA patients. And of these, they adamantly refused to proceed with a full night titration study or in-home trial of PAP. How many of you have come across those kind of patients? They're like, yeah, okay, there's no way. I'm sorry?
Thinking, why are you here?
What?
You're telling me you're going to use it.
Exactly. So the comment was, you're thinking, so why are you even here if you're refusing to try this out, right? Doctor, yes. Right, yeah, doctor told me I had to do this. And so this actually helps those patients take it to the next level. And so the cool thing is they elected to proceed with a PAP nap instead. Okay, so that's the cool thing here is they said, no, I will not go for a titration study, but I'm willing to go and do the PAP nap. So what were the risk factors for this and indications? There were basically, it was looking at the different encounters that they had with the sleep center personnel. They kind of defined who is good, who is not good for this. And they completed the PAP nap, which has the elaborate desensitization program, which we already talked about, which is a less challenging introduction to PAP therapy. And it does not have that extended usage of the PAP like you do with a typical sleep study. Then both emotional aversion and lack of motivation were assessed. And we're going to talk about this a little bit. And that's pre and post PAP pre and post PAP nap for the patient. Okay? That is, once again, emotional aversion and lack of motivation. So what were the results from this study? So at intake, you all know intake, right? At intake, the common risk factors were depression, insomnia, and claustrophobia. And you can see here, insomnia and claustrophobia here were the same commonalities as the previous study. The only other change here was the addition of depression and the subtraction of anxiety in this particular case, or in this study rather. But in general, the most common things were indications were reluctance, anxiety, and claustrophobia. So this is very similar to the original study right here, indications versus the risk factors. So you asked about how much time was used. In this case, the procedure averaged a little over 3 hours. Okay, that included tech coaching time as well as nap time. So I want all of you to pay attention right here in particular. Look at that tech coaching time. That was 83 minutes. So a huge chunk of the time was about education. And that's the education that you can provide. Now, I forget the gentleman's name, last name Lindsay, who just spoke earlier. And he talked about the fact that physicians, when they see the patient, they do not have the time to have these kind of conversations with the patient. And that is up to you to do. And you cannot replace that with AI. You cannot replace that with a PAP, with an app. You can't replace that with anything else. That's the human interaction that will guide this patient through the usage of their CPAPs. And then napping is about 107 minutes. Now, if you remember from the previous study that we talked about, the 2008 article, they averaged about 100 minutes there. So we're looking at a little over 1.5 hours is the average for these patients. One and a half hours sleep time, a little over 1.5 hours sleep time. Okay, so take a look at this. 99% required advanced PAP therapy compared to the baseline emotional aversion. And motivation improved for the entire sample, and 86% of them completed full night titrations, and 78% of them filled their PAP prescriptions. So you think about that. Those patients that finally decided, they first said, I am not going to go in for a titration study. They actually said, okay, I'm willing to do it now. The big chunk of them, 86% of them, and then of that, nearly 80% filled their prescription. After initial follow-up, 71% were users, and a smaller amount, 30%, nearly 30%, were non-users. Okay, so the other part of it is the psychological piece that we talked about, that greater decreases in emotional aversion and greater increases in motivation. So yesterday and today we heard some people talk about specifically from y'all in the audience, talk about adherence and compliance and how that's important for the industry as a whole, for patient to be using that. And that's a huge piece of it here, is the fact that increases in motivation to actually use the therapy. So in conclusion, what comes about this was associated with a sizable portion of highly reluctant patients proceeding to titrations they had rejected, and the majority achieved PAP user status. So you think about that. From aversion to PAP user. It's a huge, huge change from what has happened in the past. So I hope you can see from the study, 10 years later, the value of including a PAP-NAP program in your sleep centers. They also noticed improvements in emotional aversion and motivation. We just talked about that. And at the end, they also said, we need to do this was a retrospective study. Basically, they took a bunch of patients they already took care of and looked at that. But they feel that randomized control trials must assess efficiency in the future. So let's put this together to your question about, okay, how do you do this? So we talked a little bit about the indications. Now I pulled this off of the CMS website, okay, according to CMS. Now, if you go onto the CMS website, you'll also see that just because we put it here does not mean we're going to pay you back. That's, in summary, but it is off the CMS website. So why would you use this? It's to correct noncompliance or improve compliance with the prescribed PAP therapy, to decrease anxiety and or claustrophobia that's associated with CPAP, for patient education, and mask pressure desensitization. And finally, has anybody heard of this? Cognitive behavioral therapy, CBT? Yes. How many CCSHs here, by the way? Do we have anybody that has CCSH? I saw a couple here earlier. I would highly encourage you to look into that. It's something that we heard some people talk about it yesterday, and I would do the same thing. Is I would really push you all to look at that. It's sleep educator credential, and all these pieces are huge when it comes to CCSH. So cognitive behavioral therapy. So one of the most interesting things about this is the limited leads. What does that mean when you do a PAP-NAP? What is meant by limited leads? We're going to talk about that in detail. And how long is it? Anywhere from 60 minutes to 1.5 hours in bed. That's what we have been seeing in average, but seeing on average in these studies. So pre-test instructions, I told you we're going to talk a little bit about that, a little bit more. What were the two pieces that I said that this mainly is used for? Does anybody remember? Sorry? Anxiety and claustrophobia? Yes, so that's the psychological. What's the other piece? Compliance, so that's the physiological, to be able to use the machine, right? So your pre-test instructions have to relate to that, okay? Now, what I've seen in some sleep centers is they use the Pittsburgh Sleep Quality Index as part of their workup, the intake for a PAP-NAP, okay? The other part is, what do you tell people when they come in for a sleep study? What do you tell them, by the way? What should they do when they come in for a sleep study? Sorry? What do you do to prep to come in? Sorry? Bring your pajamas. Yes, somebody said caffeine. Drink a lot of caffeine. No naps. Yes, so what's that? Yeah, so it's no cigarettes. Yes. Talking about cigarettes and caffeine, I got to tell you this story. So there's a friend of mine. He is registry number 006. Yes. Yes, 006. And he had this habit when he would go in and run a study, bag of Hershey's Kisses, pot of coffee, and he had his cigarettes, and I can't remember what he smoked. And he was a tiny little guy in his pocket. And then, he'd go out and he would light up, come back in, and this is all he would. And I was like, yeah, Hershey's Kisses and caffeine. And I was like, what's that? He never got big. He was a really skinny guy. It was the cigarettes, man, and the caffeine. I was like, dude, how do you do it? He said, man, you got to fuel up. If you're going to be up all night, you got to fuel up. And I had seen him several years later. He was very, very pale, and somebody told me he had like a severe ulcer, and I wonder how that happened, right? So, great guy. I learned a lot from him. Okay, so pre-test instructions. So, first off, no naps the night before or the day before, no naps, because you have to have them nap in the next day, right? The other thing is no caffeine the day before, at least the night before, no caffeine. And no caffeine in the morning when they come in. Okay? Now here's the next part, which is also very important, is that they need to shorten their sleep time by 1 to 3 hours. So say that they go to bed at 10 o'clock at night, they need to go to bed much later and reduce the time that they're actually asleep in order to help elicit an actual nap in the daytime, force them to go to sleep in the daytime. Okay, so that's also extremely important. And finally, somebody needs to be available to pick them up, drop them off to the sleep study and pick them up, because they're going to be sleep deprived, and you don't want that on you, right? So they need to make arrangements for transport to and from the sleep center. The other part of it is, like I told you about the Pittsburgh Sleep Quality Index, anything that assesses their emotional state, because there is a psychological component to this as well. So these are the main pre-test instructions for the patient. So one thing to keep in mind is monitoring sleep may be ideal, but this is not a titration study. Yes, we will keep in mind that, hey, is this the right pressure for them? But you are not trying to titrate the patient. That titration is specifically a separate study for a separate night. So this is not a titration, but provides patients physiological exposure to PAP therapy, okay? That's what it's about. It's about just being exposed to PAP therapy. If that means keeping it on 4 or 5 for the entire nap, so be it. But that's what this is about, okay? It's not about, can we get to the right pressure? And it does not provide definitive sleep or breathing evaluation. So that's another thing to keep in mind. You'll see here, and I pulled this off again, off of the study, which illustrates exactly what you need to do. So what that means is you are not trying to define sleep stages here. You're not trying to define apneas, hypopneas, or any sleep disturbances. Your sole intention is to help that patient get used to the PAP therapy. That's what this is about. Yes, ma'am. No, it's a limited lead, and we're going to talk about the leads in just a bit. Sorry, the question was, are they hooked up to a complete 10-20 montage? And the answer is no, and you'll see this here. And that's the cool thing that Dr. Krakow and his team did, was they actually illustrated what all leads that they put on the patient. And that's part of the reason why you cannot define sleep. And what I was going to say is, you presume there is sleep. That's according to the study. Sleep is presumed, and also optimal titration is presumed as well. Okay, so that's the interesting thing about it, is there's a lot of presumptiveness there, because it's mainly about getting the patient acclimatized to the unit. So here are the leads that you were asking about. So the first one is your pressure transducer. You know, what is the pressure on the patient? And identifies presumptive breathing events. So you are assuming there are going to be breathing events. You're assuming also that they have been treated. And if you're using it as prior to titration, you're assuming that it's going to be treated later, but there are going to be events. That way you can look at hypopneas, apneas, full limitations, as well as, which is most important, is pressure intolerance. Okay? That is what you're really looking at over here, pressure intolerance, warranting pressure adjustment to normalize the breathing. So if you're seeing the pressure intolerance, raise up the pressure, drop the pressure, whatever it is, you do that. It is, again, not for titration. It is just to get the patient to be able to use the therapy. That's all it's about. Snore mic, that's the next lead on here. Identifying presumptive sleep and breathing types. Now, when I say presumptive sleep, you all know this very well. Now we have all the smart watches that will FDA approved for what? OSA detection, right? it's all presumptive. It's presuming that you're asleep at that point. And that's a similar fashion here, is that, okay, I'm using the snore mic to presuming that the patient is asleep, and then to see if there are any other events that are taking place at that point. PAP pressure adjustments will promote desensitization, enhance patient comfort, and respond to presumptive breathing events. Again, you see here that you have 3 points here as to why you would adjust the pressure. And 2 of those points, 2/3 of the reason for doing this, is to get the patient used to the therapy. That's what it's about. And then why do you have the pressure transducer? It is to assess leak and proper mask fit, which is, as you know, is very important when it comes to this. I haven't been inside a lab on the other side in a long time. Do people still try to get zero mask leak? Do people still do that? Try to get to zero? No? If you can. I haven't done that in a while, but you know that leak is part of it, right? Leak is part of the whole thing. But at the same time, when it comes to this, why are we looking at leak? It's mainly for the patient comfort. That's what it's about. Yeah, and it's not about yanking it down. No, it's not about that. It's about, a patient will say, I can't fall asleep because I hear this hissing sound, or I hear that farting sound, or whatever it is. I can't stand it. I can't go to sleep. This is about being able to control that to help the patient go to sleep. All right? So what is your role there at that time? Finding the right mask. Very good. What else? That's really good. Excellent. What else? Making sure it's comfortable for them. Very good. What else? Boom. That's what I was looking for, is education. Again, you cannot replace that piece of the sleep technologist with, no matter how much literature is out there, no matter how many YouTube videos out there, you cannot replace that piece for the patient. The fact that your education of the patient regarding mask and how the leak is managed, because they may not get that mask when they get home and they work with their HME provider. They may have a different mask that they're using, but the knowledge that you have imbibed in them will help them with that. Here's the next set of leads. Respiratory effort belts. Presumptive breathing events in conjunction with the pressure transducer. Okay? So you haven't heard me talk about EEG leads yet, right? Okay, there's a reason for that. As you can see now, it is because this is about, again, it's about the patient getting used to the machine. That's what it's about. You're presuming sleep, and you're presuming that the titration will or has been optimal. And also a pulse oximeter. Why is this used is not really to look for DSATs, but what it's here is to measure the heart rate to identify presumptive sleep, breathing events, and response to the PAP therapy. What does that mean to you all? I'm sorry? Okay, so comfort level and events. That's what this is actually looking for right here, is comfort level and events. Because if you can see using these channels that we just talked about, the patient seems to be steady. You have a feeling, and you guys know this as well, being sleep technologists, part science, part art, is that this patient is comfortable and is tolerating this therapy. And that's why this is used. You're not really looking at it, okay, this patient had a huge DSAT, do we need to increase the pressure? That's not what this is about, once again. This is the other channel, video monitoring. Visual assessment of position and comfort by monitoring the patient movement. And that may indicate needs for adjustment of mask and pressure. So we typically don't look at the video as part of the montage, but you know very well, especially with the newer software, it's overlaid onto the montage, right? The video channel. So with that, you can assess the patient, and that's, again, this is extremely important. You'll see the patient doing this in the middle, during the nap. You see them tossing and turning and doing this, that they are not comfortable. That's what the video channel is for. is to be able to actually visualize that and note that down. Again, this is extremely important as a sleep technologist because you're the ones who are noting this and writing that information down in order to tell how the patient is doing, and then indicate the need for adjustments to mask or pressure. That's when you would go in and help that patient with that particular issue with the mask. Body position monitoring allows for the identification of position-dependent breathing events. What is a position-dependent breathing event? Supine position, right? Yes, that's typically what it is, right? Yesterday, during Robert's talk, he talked about this new product that's FDA approved for positional OSA called Zoma. That may be something that you could educate the patient with, that, hey, we've noticed that you do a lot better on your side. You might want to add this to your therapy, this positional therapy unit with that. So you see how it all fits together? Your knowledge base, the education that you have, and the education that you can provide to your patient. That's what this is about. So something to keep in mind here, and we all know this already, presumptive sleep is assumed with the snore mic with the emergence of snoring. Okay, it's just assumed that the patient has fallen asleep. Or other presumed presumptive breathing events. What are these breathing events that tell us the patient has started to fall asleep? Outside of snoring. Come on. Sorry? Hypopnea, yes, right? And breathing slows down. Yes, exactly, right? All the typical things that you see normally, you're going to be able to assess, okay, it looks like the patient has fallen asleep. I haven't put any EEG leads on, but I can tell that this patient is starting to slow down, starting to fall asleep, because I have seen these events. And finally, steady reductions in heart rate and the oxygen baseline. You know this already, right? If patients falling asleep, they're no longer at that 99% oxygen saturation. It goes down just a touch. What's that? They weren't, well, that's in lots of cases, yes, they weren't there to begin with. But you do see a little bit of a drop there. You know that this patient is falling asleep. So here's something that, again, I have repeated this over and over and over again, but in the study that they talk about very explicitly is that monitoring of sleep might prove useful. The purpose of the PAP nap is to expose and acclimate and not titrate the patient to PAP therapy. So again, you're not looking for sleep stages, you're not looking for any EEG events, you're not really looking for any respiratory events either. What you are looking for is the patient to be comfortable on the therapy. Now, comfort, as you know, is a very subjective thing, right? And that's the psychological piece. The physiological piece are the events that we typically look for as sleep technologists, but now you are looking at the other side of it. Typically, what you do during your hookup or the setup in a titration study or in a regular study, that conversation that you have with the patient while you're setting them up, that conversation, that's the big piece here. It's not about looking for these events. It's all about the education piece, the comfort piece. It's very psychologically oriented, this specific study. So post-test instructions, what do you think they are? If I told you this much, you should be able to figure out what this should be. Okay, let's take a step back. When you do a sleep study, a standard diagnostic PSG, or a titration study, what are your post-test instructions? Follow up with your doctor? Yes. What else? Fill out this form and get the hell out of here? No. What else? How did you sleep? Very good. Yes. What else? Morning questionnaire. Yes. Good. What else? Instruction. There you go. Instructions at home to use the CPAP while they're watching TV or doing any other activities while awake. Very good. To help acclimate. Very good. What else? Educating them again, once again, reiterating. So you saw that according to the study, the second study, the big piece of this, a big piece, 83 minutes was tech interaction with the patient. Is all education. So all these pieces that you talked about is the post-test instructions. One thing we did not talk about is the fact that, hey, do you have a ride? You can't leave here unless you make arrangements to take you back. That's the other piece. But apart from that, all these pieces that you talked about, don't worry, I'm leaving. Okay, so, all right, so all these other pieces that you talked about are part of the post-test instructions, okay? Patient education. What was this all about? Why is CPAP important? All the comorbidities associated with obstructive sleep apnea, all those pieces are a big part of it as part of the post-test. Using your CPAP when you're awake to, just like we did the nap here, try to take naps with it. If you're watching TV, put it on, those kind of things. Using your CPAP. And any other tips, tricks, how do you use the mask, how do you fit that, all those things. Fantastic. So what she said was giving them hope for the future. Okay, you did this well during this PAP nap, but in the future, give yourself a month, 2 months, 6 months. Like me, when I used CPAP, it took me about 9 months to get used to it. So giving them hope that in the future, if you continue to do this, this is going to get better. Very good. And that's a huge point when it comes to PAP naps, is that psychological piece that is often forgotten when we are doing our regular day-to-day work. That's what comes into play with the PAP naps.
Should they not do it 4 hours, since they have to do 4 hours to keep the machine for a month, or they get the machine taken, insurance to take it once? It seems like you would try to get them to comply for 4 hours. You know, if they can do 4 hours a day,
Right.
30 days, then isn't that how their insurance is? They take their machines away?
All right, so the question was, should we get them to do 4 hours, because is that what insurance requires in order for them to keep their machine, otherwise it'll be taken away. Okay, so that is part of it, yes, but that's not the PAP nap. So in regards to the education, is helping the patient get past that 4-hour mark, or get to and then past the 4-hour mark. That is a huge piece of it as well, is that patient education. Okay, you used it for about 90 minutes here, or 100 minutes here in the center, in the lab. How do we get you to use it for 4 hours? Because your HME requires you to do that in order for insurance to pay for your therapy. Then how do you get to use it beyond the 4-hour mark so that you get the most benefit of it? You know, you got AFib, clears up. You got hypertension that helps bring it down. All those pieces in there. How do you get that patient? And that's part of the education that you provide as a sleep technologist. So we were talking about reimbursement. Jerry, show me the money, right? Yeah. You all have seen this picture, right? Yes. Okay. Yeah. So, show me the money. We talked about the code. So let me go back to, once again, I'm not a billing expert. I'm not a lawyer. I put it on record that I'm not any of these things, so this is based on my knowledge from the study. Once again, the criteria meets CPT code 95807 that includes 4 more sensors, including simultaneous recording of ventilation, respiratory effort, ECG or heart rate, O2 sats, attended by a technologist. Okay, this is pulled directly off the study. So, again, from the study, average procedure length ranges from 2 to 5 hours, with time usually dependent on the degree of desensitization and coaching needed for mass pressure sensations, effort to overcome emotional imagery barriers, and actual recording time. So keep in mind, the study starts when you start talking to the patient. Okay, it's not the actual recording, that's the time in bed, the recording. The study, actually, the PAP nap begins with your interaction with the patient as you start talking to them about the study, so that includes the hookup, okay? So that hookup is part of the desensitization, so you have to keep that in mind. So when you're doing the billing or when you're doing your documentation, you have to note that down, that this is when we began the whole procedure, is at such and such time, began educating the patient, began the setup, blah, blah, blah. Rare procedures are short as 1.5 hours and as long as 1.6 hours, but average time for this sample, according to this study again, was under 3.5 hours. So again, goes back to what we were talking about here. You had like almost 1.5 hours with tech time, face-to-face with the patient, and that could be while recording, it could be outside of recording, any of those pieces, but it's about 90 minutes talking to the patient, and the other 90 minutes, about 100 minutes or so, when the patient is in bed using the machine. Okay, so those pieces put together is what you get the total number of hours here. So this is another thing I found fascinating that they put in a clinical study is their conversations with Medicare, with CMS. Following our discussions with Medicare officials, we agreed that the modifier 52 for abbreviated studies should be used. So the final billing was entered as CPT 95807-52. Isn't that fascinating that this is part of a clinical study, but the fact is that they had conversations with Medicare officials, and that was documented in there. And Medicare, on the CMS website, they actually refer to this study on the CMS website. So they labeled the procedure, and this was the actual study, what it was called, an abbreviated cardiorespiratory nap study, and for billing purposes so that it matched the terms that matched the CPT code. So when you're billing, this is what you call it, abbreviated cardiorespiratory nap study. Okay? But in the sleep center, we called it a PAP nap. So for me, from a clinician side as well as a business side, what I found fascinating is this physician took his group, he wanted to find a way to further improve compliance and adherence with therapy for the patients. So he tried to find something that wasn't as invasive. Nothing on the head, nothing on the face, stuff like that. Or I say nothing on the face, but there was still a snore mic, but you know what I'm talking about, is that minimally invasive. There's no scrubbing, no 1020, none of that, and allow the patient to have a chance to fall asleep. And then they had conversations with CMS in order to be able to bill this. Why? So that they could continue doing this procedure. Now, he worked for a teaching, if I remember correctly, a teaching college, so you get some grant money to do certain number of things, but after a point, grant money runs out, and you have to somehow sustain this, right? And that was done by being able to bill for these procedures and allow patients to be able to enjoy therapy for a change as opposed to despising it. All right, so finally, I think the big question in everybody's mind is, all right, what's that? Reimbursement, yes, how much, right? Show me the money. Show me the money. What's that? That's what the hospitals do. So it is so wide-ranged what you see here, okay? Again, I'm not a billing expert, but from the research and from people that I've spoken to, I've helped people set up PAP nap programs at their centers, anywhere from $200 to $800, I've heard. So it's so wide-ranged, and it's up to you to figure out what works best with you. If you do a quick Google search, you'll see different sleep centers that offer a cash amount and and tell you how much they bill their insurances. I saw one recently, was $400 cash, and if they bill insurance, they bill it for $750. Okay, so it's very wide ranged, and you have to figure out what is important, what works for your center, and obviously what works in the state that you're from. Does that make sense? Yeah. All right, so to review what we did over here, hit all the objectives. We discussed and defined what is a PAP nap. We talked about its role in the sleep center, and most importantly, its role in adherence and compliance of PAP therapy, and finally, how to actually roll out a PAP program in your center. This is just to show you that I actually did some research and I didn't pull it out of my hat. So finally, once again, if you haven't subscribed already, please do. You get the latest information of what's going on in the sleep world, especially in sleep technology. So be sure to check on that. Does anybody have any other questions? Yes, sir.
So, as far as initiating an order for a PAP nap, do you typically see that you have to have a close relationship with the DMEs that are looking into early compliance, and they get in touch with you or the doctor, the sleep center, or the doctor? How do you start the progress of, oh, this patient's going to be non-compliant with the doctor?
Okay, so the question is, how does the process start when it comes to running a PAP nap for a patient, right? Do you work with the DME? Do you work with the doctor's office? The answer is all of those. Okay, so a patient could call any one of these people and say, I can't use this, right? I can't use this. They could call the doctor's office and I'm sick of this, I don't want to use this, blah, blah, blah. They could call you, the sleep center, and say, I can't use this, I don't know why you put me in here, I don't care, whatever. They could call the DME, take this away. It's your relationship with all these pieces, including the patient, to be able to figure out when is this process, when is the procedure initiated, right? So this is kind of like a little dance that everybody does. You have to have the right partners, work together, and then you can tango together the right way. And that really is really important, to have that close relationship with the DME provider, HME provider, and as well as the physician's offices that you get the referrals from. Okay, thank you. Yes, ma'am.
I actually wanted to ask whoever does the PAP naps and talk about insurance approval, are they more apt to approve it on a patient who has had HST as opposed to a patient who had it in that study?
Okay, I'm just going to repeat the question for everybody. So the question was for the person that they do PAP naps in their center, is the insurance, are they willing to do these for patients that have had HSTs, correct? Did I summarize that correctly? Okay, her answer was she's never done one with anybody that's done HSTs. It's mainly been those who have been on CPAP already. All right, thank you. And can you?
They do an HST, they put them on an auto PAP, and they don't do good on the auto PAP.
Right.
And so that seems like a lot of people might benefit.
Right, and so the comment was, it sounds like what you see a lot these days, somebody's been given a home sleep study, and then they get an auto PAP, and they're not doing well. This program looks like it would fit extremely well with that. And I would tend to agree with you there. I would definitely tend to agree with you there. Sorry? So you'll understand why HSTs became a thing, right? Why is that? I would say no, it's not insurance. We do believe that. I'm sorry? Comfort at home, that's one. What else is it? Yeah, well, it was before COVID, but COVID did accelerate it. They don't want, I'm sorry? There you go. It's for the patients that couldn't come in. What started happening was, especially in the VA, you started having a huge backlog of patients that just could not get a bed for a sleep study. And then studies were done that for patients who had sleep apnea, this was just as effective, only for sleep apnea, is almost as effective as having the study done at home. And so that's why home sleep studies became a thing, is in order to alleviate the pressure of patients having to wait for so long. And so in regards to that, that's how these things have to be looked at, is what is the reason for doing this and why is this becoming important? Anybody else? All right, thank you all so much for your time. You all have been great. Appreciate it.